Hello. Thank you for tuning in to watch my presentation on the Healthy People 2030 objective of reducing the overall cancer death rate. My name is Dan Edelman. I'm a board-certified family nurse practitioner as well as an oncology certified nurse and a DMP student here at the UMass Lowell. And let's get into it. All right, so I chose this issue because because cancer is a major health issue. It is the second leading cause of death in the U.S. annually, accounting for more than 600,000 deaths annually, according to the most recent statistics. This presentation focuses on the Healthy People 2030 objective, C-01, which aims to reduce the overall cancer death rate and seeks to approach this subject from an epidemiological perspective. So before I get too far into this conversation, I thought it would be helpful and maybe relevant to explain why I chose this topic specifically. I have both a personal and professional interest in cancer. On a personal level, although I've never personally been diagnosed with cancer, thankfully, cancer has affected many family members of mine over the course of my life, and I know firsthand how devastating it can be to not only to patients but their families and loved ones. I also have great professional interest. I'm an oncology certified nurse, and although I don't currently work in oncology, I spent the overwhelming majority of my adult professional life working in one variety or another in oncology related care. I was a nurse for almost 4 years at Brigham and Women's in the inpatient oncology service, and I did the majority of my nurse practitioner clinical training at the Dana-Farber Cancer Institute. I love oncology because I appreciate the complexities of oncology care, and I really value being able to make a small but positive impact on a person's life during a profoundly difficult chapter. It's not easy work, but I find it very professionally rewarding. All right, so the HP2030 objective from the website. Let's take a look. So the objective is to reduce the overall cancer death rate. According to the most recent data, cancer accounts for 141.8 deaths per 100,000 people. For the HP 2030 objective, they set a target of reducing this death rate to 122.7 per 100,000 people. It's important to note that the overall cancer death rates have been falling, but as I'm going to get into right now, I think that's a slightly incomplete statistic. So, what does the falling death rate actually mean? Is it valid? Why and why not? So, although it is true that the overall death rates are in fact decreasing across all types of cancers, this can be slightly misleading because the overall incidence of cancer has increased dramatically over recent years, particularly in some specific types of cancer, such as early onset colorectal cancer, which I'll cover in one of the research studies. So yes, death rates are falling, but the incidence is going up. So in terms of total progress against cancer, it's not as, promising as the death rate would suggest by itself. All right. So cancer is very broad and refers to literally like hundreds of different types of cancers according to that are classified according to a variety of different ways. So I thought it would be helpful to discuss the commonalities. What is cancer? What causes it? How do cancer cells behave differently from normal cells? How is cancer staged and classified? And then some of the current standards of care before I delve into the research that I evaluated in my recommendations. All right, so what is cancer? Cancer is a group of diseases characterized by the rapid and uncontrolled growth and division of abnormal cells that can invade and destroy normal body tissue. These malignant cells can then spread to other parts of our body via the bloodstream or lymphatic system, a process which is called metastases. While there are many different types of cancer, they all share this fundamental characteristic of uncontrolled cellular proliferation. What causes cancer? This is the billion or maybe even $1 trillion question. There's a lot we know and a lot we still have yet to discover. So we know that cancer starts when something goes wrong in the normal process of cells growing and dividing to make new cells. Something in the cell's DNA mutates and changes to make the cell become abnormal or pathologic. Most cells die when they become abnormal due to a process called apoptosis, but in cancer cells, a mutation occurs that allows the cells to survive, grow, and rapidly divide to make more abnormal cells. What causes this? So there are many possible causes for the genetic changes that lead to cancer, including lifestyle habits, familial or hereditary predisposition or genes, exposure to certain carcinogens, such as various chemicals or radiation. Many times, normal cells slowly become pathologic due to a combination of these factors, and sadly, sometimes there is no clear cause. So I'm not going to discuss this in too much detail, but if you want, this is a valuable slide which compares how normal cells behave versus how cancerous cells behave. And you'll see that with regard to shape, to like how they grow, proliferate, get blood, and derive energy to like grow and spread, they behave very differently. Cancer cells are like generally poorly defined, boundaries, lack a clear nucleus, and rapidly divide. Classifying cancer. So broadly speaking, there are two major types of cancer classifications. The first is hematologic cancers. This refers to cancers that originate in the blood or lymphatic systems. These are often referred to as liquid tumors. Some of the most common types include leukemias, both ALL and AML, lymphomas, which are cancers that originate in the lymph nodes. This includes both Hodgkin's and non-Hodgkin's lymphoma, and multiple myeloma, which is a rare type of blood cancer that originates in the plasma cells located in bone marrow. The other major type of cancer are referred to as oncologic malignancies. This refers to cancers that originate in solid tumors, like carcinomas that come from the epithelial lining of solid tumors, or sarcomas, which are cancers that begin in the soft or connective tissues. Cancers generally tend to be classified by the primary organ where they are found, via the extent of their disease. For example, stage 4 lung cancer. And the extent of disease regardless the cancer is staged 0 through 4. Stage 0 referring to carcinoma in situ, which is the earliest form of cancer, ranging like all the way to stage 4, which refers to distant metastatic disease, and is generally associated with much poorer prognosis. Current screening guidelines and standards of care. So current cancer screening guidelines, they are imperfect and constantly evolving. One example of this would be the age recommended that people start routine colonoscopies. It was recently, within the past 5 years, lowered from age 50 to age 45, and that's due in large part to the increase in early onset colorectal cancer. And then current standards of care therapeutic regimens, regardless of the type of cancer, overwhelmingly the first-line treatment regimens involve some combination of chemotherapy, radiation, and surgery. These treatments work by targeting rapidly dividing cells. They can be very effective, but they also are notable for having a lot of side effects because cancer cells are not the only type of rapidly dividing cells. GI, mucosal cells, hair cells are just a few types of cells that normally rapidly divide. So these treatments, though they can be effective in treating the cancer, they come with a variety of side effects, and they also suppress the body's ability to fight against the cancer itself. There are a number of exciting new innovative treatment modalities that we've been introduced to over the past few decades. Probably most famous is cellular and immunotherapy. Broadly speaking, these treatments are designed to mobilize our body's own immune system to identify and fight the cancerous cells. This is a completely different treatment approach, but one that's certainly exciting. All right, cancer mortality statistics. Briefly, wanted to talk about the cancers with the highest mortality rates. So first is lung cancer. It's the leading cause of cancer death, both in the U.S. and worldwide, responsible for roughly 20% of all cancer-related mortalities. Second is pancreatic cancer. Pancreatic cancer is often diagnosed late because it presents with non-specific GI complaints such as nausea, diarrhea, or reduced appetite. It has an extremely low 5-year survival rate of 12 to 13%. Colorectal cancer. There's a concerning rise of early onset colorectal cancer in patients age 50 and younger. Liver cancer and esophageal cancer round out the top 5 of types of cancer with the highest mortality rates. Cancers with the lowest mortality rate, number 1 is testicular cancer, which boasts a impressive 93.55-year survival rate. Various types of skin cancer. This includes basal cell carcinoma, squamous cell carcinoma, and melanoma, which is the most aggressive and deadly type of skin cancer. Prostate, which is the most common type of cancer in men. Thyroid cancer, and breast cancer, which is the most common type of cancer in females. Of note regarding breast cancer, there are many different subclassifications, largely based on the presence or absence of various hormonal receptors on the actual tumor, like the estrogen receptor, progesterone receptor, or the HER2 receptor. And broadly speaking, cancers that do have these receptors present, they have more treatment options and are typically associated with better outcomes versus the types of breast cancer which don't have these receptors present. These are rarer, but they tend to be more difficult to treat and are associated with a poorer prognosis. All right, so the first research study is titled Cancer Statistics 2023, very creative title. So the purpose of this was to provide a comprehensive overview of cancer occurrences based on U.S. population data. The data was derived, it's population-based cancer incidence data in the U.S. collected by the National Cancer Institute's Surveillance, Epidemiology, and Results Program. Some of the notable findings across both genders, male and female, there's roughly a 40% lifetime probability of both men and women being diagnosed with a type of invasive cancer. This risk is slightly higher in men than in women. In men, the most common type of cancers are prostate, lung, and colorectal, prostate being the most common, accounting for 29%. In women, the most common types of cancer are breast, lung, and colorectal, and breast cancer alone accounts for nearly 1/3 or 31% of all female cancers. There are notable racial and ethnic disparities. Overall, cancer incidence is highest among white people. However, sex-specific incidence is highest in black males, roughly 79%, higher than the lowest racial group, and approximately 5% higher than in white men, which are the second-ranked overall group in terms of incidence. The strength of this study is the large volume of data and the inexpensive data collection techniques, as well as the thorough statistical analytical models that were employed. Some of the limitations include model-based projections lacking of ability to predict trends, their failure to anticipate and account for improved modeling techniques and cancer surveillance coverage, as well as models' inability to anticipate abrupt fluctuations for cancers that are affected by changes in detection practice. So this study concludes that cancer mortality rates have been decreasing steadily since 1991, roughly overall decrease of 33%. This steady progress is driven by a number of factors, including smoking reduction, uptake in screening for certain types of common cancers, such as breast, colorectal, and prostate, and improvements in treatment options, especially in some of the most difficult to treat cancers, such as lung cancer and metastatic melanoma. There is a concerning rise of incidence in breast, prostate, and uterine cancers, all of which have a wide racial disparity and are known to be amenable to early detection. Expanding access to care and increasing investment in the broad application of existing cancer control interventions would help to address the racial and ethnic disparities and accelerate progress in the diagnosis and treatment of many types of cancers. All right, the next study is titled Epidemiological Classification Changes and Incidence of Early Onset Colorectal Cancer. This was an important study because of the previously noted increasing incidence of early onset colorectal cancer during a period which also coincided with cancer registration guidelines changing their classification criteria. The objective of this study was to describe patterns in colorectal cancer incidence according to histopathological type. It is a population-based retrospective cohort study. Some of its strengths are that the analyses relied on population-based data, which is considered the gold standard for studying incidence patterns. Some limitations are derived from its limited geographical coverage. It only covered 4 administrative areas in France. This warrants caution when extrapolating results to broader, more diverse populations. And the article concludes that the overall incidence of early onset colorectal cancer increased only in the ages 15 to 39 class, but remains stable in the age class of 40 to 49 years, and slightly decreased in the age class of 50 years or older. Needless to say, there are important implications for public health decision makers to consider. All right, so addressing the ongoing cancer-related research gaps. So there are a number of gaps, and I decided to go by primary level and on. So on a primary and prevention level, we want to continue to identify causative and preventative agents for various types of cancers. We also need additional research supporting the development of cancer vaccines with the goal to prevent carcinogenesis from ever taking place in the first place. On a screening or secondary level, we need more research focused on improving screening access, designing interventions and protocols that meet the five protocol for good screening tests discussed in week 8. Protocols that are simple, rapid, inexpensive, safe, and acceptable. We need to continually be working to improve reliability, validity, and cost of these screening methods. On a tertiary level, we need to continue to focus research, design, and implementation that supports novel methods of treatment, such as immunotherapy and cellular therapy. We need more research focused on personalized and precision medicine to continue to deepen our understanding of why certain people respond better to various treatments, for example, immunotherapy, cellular, or other type of targeted therapies than others. All right, practice recommendations. On an individual level, we need to focus on education, double down on what we already know. We need to educate our patients about the importance of limiting and or eliminating exposures to known toxic substances that have been linked to cancer. This includes cigarettes, alcohol, and various chemicals. We also need to educate our patients continually on making healthy dietary and lifestyle choices. We need to focus on maintaining a healthy weight and making an effort to add to our diet foods with known antioxidant and anti-cancer effects, such as turmeric, green tea, cruciferous vegetables, and berries, just to name a few. We need to continue to educate our patients on the importance of regular screening, particularly in those identified as high risk, as well as those in the survivorship phase. On a tertiary level, we need to continually question the current standards of care and ask ourselves whether chemo, radiation, and therapy as first-line treatment is still warranted. Are there better treatment options? And generally speaking, we need to adopt a holistic, integrated approach to oncology care, one that emphasizes dietary and lifestyle choices as viable alternatives and or as adjuvants to support current standard of care and or alternative treatment regimens. On a systemic macro level, we need to work to expeditiously implement research findings into the current standards of care. Sometimes there can be a lag from discovery to wide-scale implementation of a decade or longer. That equates to countless thousands of lives that could have potentially been saved if we work to decrease the lag time. We need to work to develop systems and procedures to effectively integrate AI technology to increase access and effectiveness of screening and to establish better risk stratification techniques. We need to work to address screening and treatment disparities to various racial and demographic groups, particularly in our most vulnerable and at-risk populations. In terms of recommendations for future research on the whole, we need to take a more epidemiologic approach to cancer-related research, reconsider the allocation of funding, shifting away from incredibly expensive tertiary treatments towards primary and secondary prevention, which can be more cost effective. We need to continue to research initiatives aimed at deepening our understanding of carcinogenesis and of how those various treatments work and affect individuals differently. We need to continue to develop novel and innovative treatment options, immunotherapy and cellular therapy, just to name a few, but generally speaking, less toxic treatments with better side effect profiles. We also need further research to improve affordability and access to innovative treatments to address disparities in access across various racial and demographic groups. In conclusion, despite the exciting advances we've made in cancer care and research over the past decades and a decreasing overall death rate, overall incidence rates of cancer are higher than ever before and continually rising. This is a concerning trend. We still have much to learn with regard to oncology care, in particular regarding our understanding of how and why cancer develops and designing treatments based on this knowledge. Finally, although some of these trends are certainly concerning, there are also many reasons for great optimism with regard to achieving this Healthy People 2030 objective. I remain truly optimistic that with the right effort and focus, it is possible and maybe even likely for cancer to be completely eradicated during our lifetime. Thank you for watching. Here are my references, and feel free to reach out if you have any questions.